Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Great, thanks. And great to be back again with the Echo crowd. I've enjoyed these in the past and look forward to a really rich discussion today on aspirin for primary prevention of atherosclerotic cardiovascular disease events in people with HIV. I'll say you can feel free to jump in. I have no disclosures, but if you want to just wait until the end of the presentation, we can have questions then as well. This is the outline. So we'll talk first about aspirin for primary prevention in the general population, and then we'll move to treatment disparities in aspirin prescriptions for people living with HIV, or people with HIV. Talk a little bit about the specific situation of Abacavir, and then really to come back to the idea of secondary prevention as being very different than primary prevention. So the take-home message is this. It's all about weighing the atherosclerotic cardiovascular disease risk and potentially colon cancer risk as well with bleeding risk. And if the atherosclerotic cardiovascular disease risk exceeds the bleeding risk and the potential absolute benefit of aspirin in reducing that risk exceeds the bleeding risk associated with aspirin, then you do prescribe or do recommend in an individualized discussion with your patient that they take aspirin. Whereas if the opposite is true, these are the situations where you don't want to recommend aspirin. So how do we get to making decisions about those things? Well, I'll start by saying in the general population, a lot changed in 2018 when there were 3 major trials published that year that included mostly older patients at moderate to high risk of CVD. And they were called Aspirin, Ascend, and Arrive. And this is the Aspirin trial as an example, published in the New England Journal. So you can see that in the Aspirin trial, the relative reduction in ASCVD events was actually not statistically significant, whereas there was a statistically significant increase in major bleeding. And the other trials were similar. And so this really got taken up in the lay press, including the New York Times as shown here, where there were headlines. You saw headlines like daily low-dose aspirin no longer recommended by docs. And what got lost in the shuffle sometime is that, they added this caveat, if you're healthy. Again, this is primary prevention. Unfortunately, as we'll talk about later, is that for some patients who had prior heart attack or stroke or had stents, they were coming to us saying, oh, should I be stopping my aspirin? No. You should not. That's a different situation. So then, based on these new trials, the USPSTF came out with new recommendations in 2022, and there's a nice New England Journal Watch from May 3rd, 2022 that covers this. And the new recommendation is to individualize decision to initiate aspirin for middle-aged adults, age range 40 to 59, with 10-year cardiovascular risk greater than 10%. And they recommended against initiating aspirin in older adults over 60. So you can see here on the right side of the screen kind of the history of the USPSTF recommendations over time. I just thought this was interesting, again, from that Journal Watch article, showing that back in the 1980s, they said consider, and then insufficient evidence. Then it kind of became strongly recommended for a time. Then in 2009, they started to put some parameters on things, and again, kind of gradually coming back to a more restricted recommendation. So that's where we are in 2022. I also want to be very practical in recognizing that many of us clinicians use UpToDate and would recommend very highly this article on aspirin in the primary prevention of cardiovascular disease and cancer, where you can find a table that shows the anticipated absolute effects over 10 years for people with different levels of risk. So if you take a low-risk population with aspirin, a baby aspirin, 75 to 100 milligrams, you would see 5 fewer MIs, 1 fewer stroke, 4 more major bleeds, and 7 fewer colon cancers. Whereas a higher risk person also will have obviously more MIs reduced, but also will have more bleeds because they also tend to be at higher risk for bleeding. So kind of an interesting table if you need it. So what about people with HIV? Are people with HIV any different? Well, we know from some interesting work by Joe Ladapo when he was at UCLA that people with HIV tend to be prescribed cardiovascular disease prevention drugs at lower rates compared to people without HIV. This is particularly true for statins and aspirin. So maybe at the time, this reflected a treatment disparity and in retrospect was maybe a benefit for these people if there was harm. But, for statins, it was pretty significant. And I think these treatment disparities, unfortunately, still exist in many health systems. So let's talk about Abacavir. I showed these slides last time we talked, when we talked about antiretroviral therapy and cardiovascular disease risk. This is the original publication from Lancet by the DAD group showing that recent but not cumulative use of Abacavir use was associated with about a twofold higher risk of cardiovascular events. This then was updated. This analysis was updated to show that the relative risk post-publication of that initial 2008 article was actually the same. Even though prescribing of Abacavir went down a bit, the relative risk associated with Abacavir remained about twofold. So people were very interested in why this was. Is it platelet reactivity, as some people seem to show, or inflammation, as shown in this ACTG study led by Grace McCumsey and colleagues? But what I found really compelling was an analysis that DAD did of their recurrent MI data. In other words, they took everyone who had an MI and they asked the question, what happened if they continued Abacavir after their first MI, and how did that compare? How did risk compare of a subsequent MI compared to people who did not continue Abacavir? And what they found is that cumulative post-MI exposure was not associated with risk, and recent post-MI exposure was not statistically significant. And so they proposed a possible explanation of that being that people who have an MI get put on aspirin, and maybe the aspirin counteracts the platelet reactivity effect of Abacavir. And so I use this as evidence to sometimes push, just as one more thing to push towards use of primary prevention aspirin in patients who are on Abacavir-containing regimens. So I want to finish up by saying a few things about secondary prevention. So obviously when we talk about primary prevention versus secondary prevention, we kind of think of that New York Times article that really had that tag at the end that said "for healthy people," right? So that was saying that for primary prevention, we're talking about people who have never had an atherosclerotic cardiovascular disease event like an MI, a stroke, or symptomatic PAD, whereas secondary prevention is for people who've already had those events. Well, as we've done a lot more testing for subclinical disease, there has emerged a concept of what I'll call primary plus, which is these patients who have CT scans that show like maybe some significant proximal LAD disease as shown here, or diffuse multivessel disease. These are people who I think you might want to treat differently, even though technically it's a primary prevention situation. And in the HIV world, we have like the Reprieve study, for example, which did a lot of CT scans in some of our patients at certain ACTG sites. So this would be my recommendation. I think in primary prevention, it's something to consider for certain people based on an individualized discussion. For people who have significant subclinical disease, I would say it's probably indicated. And then definitely for patients who've had a prior MI or stroke, they need to be on aspirin lifelong to reduce the risk of a recurrent event. A word on P2Y12 inhibitors. Obviously, these are also other antiplatelet drugs that we use in combination with aspirin in the secondary prevention situation. Ticagrelor is contraindicated. And then clopidogrel and prasugrel also have interactions with cobicistat and PIs. But since prasugrel is more effective, it's a stronger drug, its antiplatelet effect is preserved, and that's what the recommendation is for people on a protease inhibitor, cobicistat. So in conclusion, I want to leave you with my kind of take on the USPSTF recommendations for people living with HIV. And so I would say we should be individualizing decisions to initiate aspirin for primary prevention of ASCVD events in middle-aged adults with HIV, meaning 40 to 59 years of age, with 10-year ASCVD risk greater than 10%, or on Abacavir, or with significant subclinical coronary disease on CT. In other words, the primary plus situation. And that we should be generally avoiding aspirin for primary prevention among older adults with HIV, which is over 60 years old. I'll end there and happy to take any questions.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.